So I picked a couple of topics that I think might be useful for you. One of the topics will be breast cancer risk. How do we assess our risk of breast cancer? A little bit about breast density, because some new headlines occurred this year about breast density, and there is actually a new Pennsylvania law that has been passed regarding the breast density on mammograms. And also a little bit about cancer genetics, because another headliner this year was about Angelina Jolie having surgery for breast cancer because of a certain mutation. And we've had a lot of phone calls, and a lot of patients are more interested in breast cancer genetics. And also, this year, the United States Supreme Court made some important changes in the law regarding genetic testing. So it is more available, and more companies are offering it. So it is easier nowadays to offer genetic testing to our patients. So getting started, I want to inform you that there are today about 14 million cancer survivors who celebrate their birthdays this year. So I think this is quite impressive. And as far as our risk of developing breast cancer, it is about 1 in 8 women. So in this room, about 1 in 8 of us at some point in their lives will be touched by this diagnosis of breast cancer. So for the year 2014, the American Cancer Society statistics actually informs us that there have been about 232,000 new cases of invasive breast cancer, so these are a more aggressive type of breast cancer. 62,000 cases of non-invasive breast cancer, which are mostly cured. And about 40,000 women will die this year of breast cancer. Now, the good news is that the breast cancer incidence has been decreasing, and also the breast cancer mortality has been decreasing, meaning that the number of new cases is decreasing, and those cases that are diagnosed actually live longer, and there's a smaller number of women who die of breast cancer. And what is the cause of this? Well, it's a multitude of factors, but we know that increased awareness, just like we do today, and making women aware of changes in the breast that they need to bring up to their physicians, aware of the availability of mammograms and screening methods. Even cancer genetics and genetic testing has helped decrease the incidence of breast cancer. In addition, there have been major improvements in the treatment of breast cancer, and I won't have time to go in detail today about the new drug treatments that are available for the treatment of breast cancer, but there are many that have been brought to the clinics in the last couple of years, and they really have made big strides in the treatment of breast cancer. So what are the breast cancer risk factors? Obviously, being a female is a major risk factor, the most important risk factor. Although you should know that men get breast cancer too. So the women have 100 times higher risk of breast cancer than men. But there are men who develop breast cancer, and sometimes it is genetically linked, so it is caused by a genetic mutation. And in general, we do consider men who develop breast cancer candidates for genetic testing. Aging. So just the fact that we're getting older is another risk for breast cancer. As I mentioned, 1 in 8 women will develop breast cancer. In younger women, the incidence of breast cancer is lower, so only about 1 in 8 breast cancers develop in women that are younger than 40. But once you pass the age of 55, your chance of getting breast cancer is higher, and 2 out of 3 breast cancers develop in women who are older than 55. That's why it's very important to get your mammogram after the age of 50, because that's when the bulk of the breast cancer starts to be diagnosed. Genetic factors or genetic predisposition make up about 5 to 10% of the breast cancer cases. So you can see that it's actually the minority of the breast cancers that are caused by a genetic mutation, and I'm going to explain to you what that is. Family history of breast cancer is a biggie, and a lot of times when we ask the patients about their mothers and sisters and aunts, we discover a history that shows up in several generations, which to us raises a red flag regarding genetics and inheritance of breast cancer. So just looking around in your family and being mindful of who in your family has been diagnosed with breast cancer will help you assess your own risk of developing breast cancer.
Personal history of breast cancer is also very important. So unfortunately, once you, for example, have developed breast cancer, you have a higher risk than somebody else who hasn't had breast cancer of getting a second breast cancer. So that's why any breast cancer survivor will remain in the attention of the physician caring for that patient for a prolonged time, looking for the potential of development of that second cancer. Even a breast biopsy, so just a simple biopsy without diagnosis of cancer, can be linked with an increased risk of cancer if that biopsy has shown several changes that are linked with an increased risk of breast cancer. So for example, one of that changes are atypia. So when we take a biopsy and we look at the breast tissue, and the breast tissue does not look normal, we call that atypia. So there are certain criteria that the pathologist use to diagnose atypia, and if we get that diagnosis back, that certainly increases the risk of a subsequent breast cancer. Those women with a diagnosis of atypia on a breast biopsy are actually candidates for chemoprevention or methods to prevent breast cancer. We consider their risk of getting breast cancer high enough to warrant treatments, and there are several treatments out there to prevent breast cancer. Another diagnosis that is linked with an increased risk of breast cancer is a diagnosis called lobular carcinoma in situ. So this is also a non-invasive type of cancer, which we are nowadays trying to remove the label of cancer from the name. It is called lobular carcinoma. So carcinoma in general means cancer, and it's called in situ, or LCIS is the label we use. But it is a marker of increased risk of breast cancer. So these women, just like the women with atypia, have a higher risk of getting breast cancer down the road, even up to 20% in the next 10 to 15 years. These women should talk to their doctors about possibilities of preventing breast cancer and methods to prevent breast cancer, and those methods are available to them. As far as the family history, there are certain components of the family history that we should be mindful of. So the risk of developing breast cancer actually increases with the number of affected relatives. So if you have both a mother and a sister that has breast cancer, your risk will be higher than if you have just an aunt. So the more relatives you have and the closer the relatives are to you, the higher the risk of the breast cancer will be. Younger age of the affected relative is also important. So if you have a mother who developed breast cancer at the age 40, your risk will be higher than if your mother developed breast cancer at age 60. So breast cancer, as I mentioned to you, in women age 70 and 80 is pretty common. So for you, if your mother developed breast cancer at 85, the risk is not as high than if your mother developed breast cancer in her 40. Number of affected relatives we mentioned. Also bilateral disease in the affected relative. So many times we always ask the patient, so did your mother have breast cancer only in one breast or both breasts? Having cancer in both breasts significantly increases the risk of breast cancer in the relative at risk. So young age at presentation and bilateral disease in both breasts are important questions to ask in any family member that has been diagnosed with breast cancer. Another piece of information that many times is difficult to take from patients is family history of ovarian cancer. So unfortunately, many times ovarian cancer is confused with uterine cancer or with cervical cancer or some other type of cancers. So knowing precisely whether your relative has been affected by ovarian cancer as opposed to cervical cancer, it's very important. Cervical cancer is very common. It's easily curable. Not so much ovarian cancer. And ovarian cancer is the one that increases the risk of breast cancer in the relatives. Personal risk factors of breast cancer. Menstrual periods. So anybody who started menstrual period at a young age and nowadays periods can start as early as age 10 or 11, increases the risk of breast cancer just because of a longer exposure to hormones during your lifetime. The estrogens, or the female hormones, are the drivers that stimulate the growth of the breast cancer majority of the time. If you menstruated up until the age of 55 or older, there are women who stop menstruating at age 65. That also increases the risk of breast cancer, again, because of longer exposure to the hormones. Women who had lymphoma or Hodgkin's lymphoma at a young age, it's a very rare form of cancer, but it is highly curable. So there are a lot of women out there who have been cured of Hodgkin's disease, but have received radiation in the process of treatment. So radiation is very frequently used for the treatment of Hodgkin's disease, and radiation, unfortunately, does increase the risk of breast cancer. Now, the radiation fields nowadays have improved, and we are much better at decreasing the risk of the breast cancer through modifying the fields of the radiation. But once you've had a diagnosis of Hodgkin's disease, you should always talk to your doctor about when you should start the mammograms and how to be proactive about screening for breast cancer risk. In the 1950s, there was a treatment called diethylstilbestrol, or DES, that was given to women who had miscarriages to prevent miscarriages. Those women in the 1940s who have been exposed to DES are also at increased risk of breast cancer because DES is a female hormone. Many times women ask, what can I do to decrease the risk of breast cancer? What can I do to prevent breast cancer? And one of the easiest things actually is to control your weight. Obesity has been frequently linked with increased risk of breast cancer, and actually it's increased risk with many other cancers as well, but particularly breast cancer. So one of the easy things that we all can do to decrease our risk of breast cancer is to be mindful of our weight and prevent obesity. So being active, physical exercise, and controlling our weight is very important. Finally, we get to the point of the dense breast tissue mammogram. So population studies have shown that women who have dense breasts tend to have a higher risk of breast cancer. So it is a epidemiological association. And the denser the breast, the higher the risk. So for example, if the breast is just slightly dense, the risk is 1.2 times higher. If it is very dense, the risk can be up to 6 times higher than the normal person. So this year, one of the laws that have been passed by the governor is a law regarding the breast density. The problem with the breast density is that the measurements of the density, as they are today on the mammogram, are subjective. So there is no objective method to say whether the breast is more or less dense. It is something visual that is done by the individual radiologist. There are certain criteria, but there is a lot of latitude for the radiologist in calling the breast heterogeneously dense or extremely dense. In addition, what we've also learned is that the breast cancer risk is not actually due to the masking effect of the cancer. So just because the breast is dense doesn't mean that the cancer will not be seen. The link is not quite precisely understood. To make it more confusing, the density of the breast actually decreases with age. But as I've told you earlier, the risk of the breast cancer increases with age. So how do we put these two together? Another puzzle is that being obese actually decreases the breast density. The breast is more fat. But as I mentioned to you, obesity increases the risk of breast cancer. So how do we reconcile these issues? So far as we know, having a dense breast does increase the risk of breast cancer, and that's why this law has been passed. So as I mentioned to you, in the information that you will receive on the mammogram, you will be told whether your breast is heterogeneously dense, which increases only mildly the risk of the breast cancer, or extremely dense, and that increases the risk of breast cancer a little bit more. In general, if we assess that one's risk of breast cancer is about 20% over their lifetime, we do advise, in addition to the mammogram, to obtain other studies. And another study that is available for screening is the MRI, magnetic resonance imaging. So what the Pennsylvania law that has been passed in February 2014 says is that if your mammogram patients should be notified in their mammogram about their breast density. And there is a special wording that has been passed in the law that will show up on your letter that you will be getting after you get your mammogram. So what that letter will say is that if your mammogram shows that your breast tissue is dense, you should know that this breast is a common finding and is not abnormal. However, statistics show many women could have dense or highly dense breast, and it can make it harder to find cancer on a mammogram and may be associated with an increased risk of cancer. May be associated with an increased risk of cancer. And here comes the other part. This information about the result of your mammogram is given to you to raise your awareness and inform your conversation with your physician. Together, you and your physician can decide which screening options are right for you based on your mammogram results, individual risk factors, or physical examination. So the information about the breast density is, as it is stated there, just to inform you and your physician. This information will be taken into account with your other risk factors, your family history, any family history of ovarian cancer, personal history of breast biopsies, results from breast biopsies, and so on. And a risk over the lifetime will be calculated. And based on that risk, your physician will decide whether you need just a mammogram or an MRI, or actually something to prevent breast cancer if your risk is high enough. A little bit about breast cancer genetics. There are two types of gene mutations that we are interested in. Germline mutations are mutations that occur in the egg or sperm and are carried with us throughout the body, and they're called germline mutations. These are the mutations that are increased in risk through families and are passed on into offsprings. And these are the ones that you can find affected family members in subsequent generations. Somatic mutations are mutations that happen in the cancer itself. So they are not passed into your children. They're not passed into families. They only happen in your particular cancer. And these somatic mutations are targeted for treatment purposes only. There are many syndromes of hereditary breast and ovarian cancer. They're called Li-Fraumeni syndrome, multiple endocrine neoplasia, prostate cancer is linked with breast cancer, neurofibromatosis type 1 is a inherited condition. But the truth is that hereditary breast cancer, or breast cancer that is passed through generation, actually accounts for a small proportion of cancer in general. Majority of the cancer is not inherited. As I mentioned, when we take a family history to determine whether a cancer is inherited or not, we look at 3 generations. We also look at age at cancer diagnosis and cause of death. And we always try to distinguish the primary cause from the metastatic side. So as a physician, many times I hear patients saying, my mother died of bone cancer. And then you start and you ask, well, but where did the cancer start? Well, the cancer actually started in the lung and then it spread to the bone, so she died of bone cancer. We actually call that still lung cancer. So we call it by where it started. So if it starts in the lung and it goes to the bone, it is not bone cancer, it is still lung cancer. So your mother died of lung cancer. The same thing with breast cancer. If it metastasizes, oftentimes it goes to the bone, but that does not mean that you've got bone cancer. You still have breast cancer that went to the bone. So it's very, very important to always wonder, where did the cancer start initially, because that's what it is important. As I mentioned, hereditary cancer syndromes are suspected when you have cancer in 2 or more close relatives, when you have multiple primary tumors in the same individual, so somebody who has had ovarian, breast, and colon cancer is highly suspicious for having an inherited condition. A constellation of tumors that are consistent with specific cancer syndromes. So again, breast and ovarian cancer tend to go hand in hand. So if you have a family that has both breast cancer and ovarian cancer, that family should consider talking to a genetic counselor. Multiple affected generations are also a red flag of genetic mutations. Now, genetic testing ideally should be done through genetic counseling. So there should be a geneticist that can walk you through your family history, through your pedigree, through your conditions, your age of diagnosis, and can pick the right test for you. Many times nowadays there are so many tests available that it's important to know which test to get to be informed for you. So we assess the personal and family medical history, the risk perception and the motivation for testing. We educate regarding the basis of inheritance and cancer risks, and we discuss the risks and the benefits and the limitations of the genetic testing, the procedure, and then what happens if the test comes back positive, so that you know what your action should be. The benefits of cancer genetic testing are you can have a more accurate determination of cancer risk, you can have personalized screening recommendations, and you have improved decision-making regarding your lifestyle. Think of Angelina Jolie. She got the genetic test and she could make a decision at her own pace as to when to have the breast removed and when to have the ovaries removed. So you can make the decisions at your own pace. There are risks of genetic testing. Once you test positive for a gene that predisposes you for cancer and you don't have the cancer, you have to generally make a decision about what you're going to do about it. Are you going to sit around and wait until the cancer happens, or are you going to be proactive about it? That is also an important decision. There have been concerns regarding health insurance. Well, I'm not going to get genetic testing because my insurance will go up. There is a law against genetic discrimination. There's been also concern about life insurance and employment. People have been afraid of getting tested because they would be afraid that they would be let go from their jobs because of genetic testing. That is also illegal. There are limitations of genetic testing, and it's important also to understand this, because many times the test comes back negative, and yet you have a family with many members affected. So the question is, I have a mother and a sister and a cousin and an aunt. Why haven't you found anything in my genes? So unfortunately, not all gene mutations are detectable. We know a small number of genes and we can test for those, but there are a lot of genes that we don't know about and we're still researching. There are also unproven efficacy of some interventions. So many times we don't know if a certain treatment is beneficial and how beneficial it could be. So there are certain approximations that we make. There are some mutations that are uninformative, and there are also mutations that are inconclusive. We call them variants of uncertain significance. We only know that certain mutations are linked with cancer, and some mutations, we find them and we don't know what to do with them. So going back to the risk of ovarian and breast cancer, so you can see in this pie that only 5 to 10% of the breast cancer is hereditary, and about 10% of ovarian cancer is hereditary. About 15 to 20% of the breast cancer is, however, clustered in family. So it develops in a family, but we don't know what is the gene that causes it. These are the genes that we know a lot about. And you can also see that these two genes contribute the bulk of the breast cancer. So the contribution of the BRCA1 gene, which I believe Angelina Jolie had, is about 20 to 40% of the breast cancer diagnosis. The BRCA2 gene, a cousin of the BRCA1, is about 10 to 30%. And the rest of the genes take a small proportion. P53, 1%, PTEN, 1%, everything else is approximately 1%. So the most important genes are the BRCA1 and 2, and these are the genes that we more often test for. But as I mentioned, certain family history and family cluster can suggest testing for other genes, such as P53 or PTEN and so on. Now, how does having the BRCA1 and BRCA2 gene compare with being a regular person that does not have this mutation? So if you are a person that does not have the mutation, your lifetime risk of getting breast cancer can be approximately 8 to 12%. if you have the mutation, your lifetime risk of getting breast cancer can be as high as 56 to 87%. That's a significant risk. That's why in women who have this mutation, we want to be proactive. And I'll tell you about what we can do. For ovarian cancer, if you have the BRCA1 and BRCA2 gene, the risk of having ovarian cancer can be 28 to 44% for the BRCA1 and 27% for the BRCA2. The BRCA gene is also associated with other cancers. So as I mentioned, men can get breast cancer. Men can also get prostate cancer. So for the BRCA1 gene, if a man carries it, the risk of prostate cancer is 20 to 30%. And with the BRCA2, the risk of prostate cancer is 30%. Pancreas cancer, if it runs in the family, is also a red flag. Pancreas cancer can be associated with the BRCA2 gene, 5%. And melanoma also, if it runs in the family, can be associated with the BRCA2 gene. So not just breast cancer is associated with the BRCA1 and 2, there are other cancers as well. When are we concerned about the BRCA mutation? What in your family history you need to know about? Breast cancer under the age of 45 is a huge red flag. Anybody with breast cancer under the age of 45 should get tested for these genes. At least one breast cancer under the age of 50 with other family history of breast cancer is a red flag. Ovarian, fallopian, or primary peritoneal cancer in the family is indication for genetic testing. Breast and ovarian cancer in the same person, definite indication for genetic testing. Multiple primary breast cancers with first diagnosed under the age of 50, indication for testing. Ashkenazi Jewish heritage with any breast or ovarian cancer is indication for testing because these BRCA1 and 2 genes are very prevalent in the Ashkenazi Jewish population. Male breast cancer is an indication for testing. Familial clustering of the breast cancer, 3 or more cases, is indication for testing. And also, triple negative breast cancer. This is a special type of breast cancer called triple negative. If you have this cancer and have been diagnosed under the age of 60, it is an indication for genetic testing. Now, what kind of testing do we have? As I mentioned, there are many tests available, and the price, of course, reflects how much information you get. So there is a comprehensive BRCA analysis that looks through all the possible mutations and possibilities and rearrangement. It's about $3,000. Now, if you look at only 3 sites of BRCA analysis and 3 Ashkenazi Jewish founder mutations, we call them, the initial mutations, you pay only $575. If you have a family member and you know what their mutation is, and you want to test just for that mutation, you pay only $475. So that's why talking to a genetic counselor and picking the specific test that is good for you can also save you a lot of money. There is another test called the BART test, which also is more comprehensive and detects deletions and duplications. And finally, the more expensive is integrated BRCA analysis, and it's $4,000. Now, a lot of insurances pay for this. And there are, so the insurance is billed a portion. The institution where the test is billed a portion, and the patient's a portion is about $1,000. What do we do if the test is positive? We can increase surveillance. We can do the breast MRI, as I've mentioned, if somebody is very young. We can do chemoprevention with a pill called tamoxifen, or we can do prophylactic surgery, removing the breast or removing the ovaries, or both. Each has a specific contribution. So the pill called tamoxifen decreases the risk of breast cancer by 53%. Removing the breast decreases the risk by 90%. As you can see, that nothing is really 100%. There is always a small risk left. Removing the ovaries decreases the risk of breast cancer by 68%, and also decreases the risk of ovarian cancer by 96%. And also, oral contraceptives, let's not forget about those. Oral contraceptives decrease the risk of ovarian cancer by about up to 60%. So we can pick out of these different methods what to do in case of positive testing. So as I mentioned, Myriad is one of the companies that offers genetic testing. There is another company called GeneDx, and it offers several different tests: breast and ovary, comprehensive cancer, gastrointestinal cancer testing, pancreatic cancer testing, endometrial cancer testing. Really, there is out there a myriad of genetic testing available. And again, I think that's why it's important to talk to the genetic counselor and find the right test for you. And as you can see, the better we learn about these genetic tests, the more we understand. This is 2002 when we first started to do genetic testing. We had a lot of results that were of uncertain significance. And you can see how the number has decreased, and the number of this testing that comes back as uncertain significance has decreased, because we have learned a lot more about genetic testing, and we can be more informed about discussing the results with you. So I think I'm going to stop here. I've talked about genetic testing, about breast density, and I'm going to let Brenda take on from here, I guess.